We're going to turn it over to our last speaker today, Renee Branch Canady, and she's going to tell us about Michigan Public Health Institute and her perspective as the CEO there and their experiences with workforce.
Thank you, Valerie. And of course, my video is failing to share, but undaunted, we're going to move forward. And hopefully you'll at least be able
it's
to.
Sharing now. We just need to be in presenter mode. Yeah, there you go.
Okay, super. Well, let's bookend this important conversation, and excited to be a part of this panel and to follow my colleague, Nicole. And so let's talk a little bit further about innovation. And quite candidly, I always describe the Michigan Public Health Institute, MPHI, as a clear and tangible demonstration of governmental innovation. Our state health department came together with the sort of insight to partner with the legislature to establish in legislation a partner, a trusted and reliable partner that they could help leverage relationships that they didn't have as a governmental entity. And so they brought together academic public health, governmental public health, community public health, and healthcare. And you'll see all of those sectors represented on our board of directors. And so it's been really an honor as a former health officer, someone who also worked at state government, and then also in academic public health, to now utilize all of those cultural norms that I'm aware of. I want to just give you a little bit on one particular task that public health institutes provide. And I want to start with some information from MPHI. In March 2020 was when we packed up and all went home to execute our jobs and responsibilities from our homes right at the start of the pandemic. We were then at that time about 402 staff that we refer to as affiliate staff. Those are folk who are MPHI employees, but they are staff to the state health department. And there's a collaborative partnership in supporting state managers to oversee their work, providing all of the benefits and all of the back office types of things to establish that workforce. And you'll see that ratio that about 62% of MPHI hires were affiliates at that time. Over the first year of the pandemic, we saw the need for this capacity growth and what we refer to as surge hiring to accelerate. And you'll see that over the months, we jumped up until at the end of that year, we had hired about 328 employees, including being able to do some hiring for ourselves to extend our capacity to support our state partners. What's particularly important is that amongst those 328 new hires, we had representation of almost 30% people of color. And when you think of Michigan as a state that's about 14% residents of color, that's a staggeringly good outcome that we had, leading with that, wanting to see communities being able to see themselves in the public health workforce. And it was a variety of roles: physicians, epidemiologists, nurses, project managers, and a variety of broad range of positions in public health. So we presently now have about 629 active affiliates that have been hired through MPHI. Of note, though, the model, the innovation, right, is that 24% of those affiliates have converted to state of Michigan civil service employees as positions became available and as the timeline was allowed. And so that in and of itself is again, innovation by design. There are also a couple of other critical things when we think about capacity for our state health department partners. Sometimes hiring a new employee to partner directly and be a part of that staff is the solution. Other times, pulling in subject matter experts from MPHI is the better solution to huddle up at the table and assist but not be a daily member of that staff and that workforce. So consultation and partnership, critically important. We also found that our extended capacity to do contract management, accountability for partners was also critically important. At the end of that first quarter of the first pandemic, our state health department reached out to us and said, we've got a $20 million opportunity. Can you help us push this money out to the community in a way that will bring accountability, will support them with technical assistance? And surely we did that. And about 2 weeks after that request, they came back with a $25 million request to push out funding for PPE into the community, both of which had to be completed and closed by December 31. So we're talking about a huge capacity that we have in public health institutes, getting that funding literally at the beginning of the last quarter of the year and being able to close that. And so when I was local health officer, I would say if you see one local health department, you see one local health department. And I know my colleagues on the panel can appreciate that. We say the same thing about public health institutes. If you see one, you've seen one. But we are a robust network of 45 plus public health institutes, the National Network of Public Health Institutes. I'm honored to serve as the president of our board, and Dr. Vinnie LaFranza is our CEO, but it is about advancing public health structures, systems, and outcomes. Right now, as a network, we are having discussions about what we're calling our high capacity institutes, and you'll see MPHI listed on that, but there are a number of large, robust institutes that have the capacity to do things like track record a record of building local capacity in state service areas, experience implementing public health initiatives of national significance, that have the ability to be robust public health subject matter experts that are on all of our staffs. We're able to track the record of supporting governmental partners, and we bring very strong financial and business acumen to the table. So our high capacity institutes are able to do all of those things, but each of our member institutes are able to do some of those things. And again, it depends on how they're aligned, how they're developed. Some are associated with universities, some remain in the nonprofit space. And so we're really excited about this robust model to assist both public health professionals in health systems, but predominantly to assist our governmental public health partners. And so I want to just close with a couple of slides to agitate not just lessons learned, because something about the past tense of that phrase caused me to think, yeah, it's really about learning lessons. We are continuing to learn, and I'm really pleased that so many of these learning lessons are resonating with the points that my colleagues made in their remarks. So first point, building capacity for the capacity builders. This is a lot. How are we scaling equity work, but also scaling work equitably? And so we have found that a commitment to sort of an inward-facing lens and an externally-facing lens has been critically important. Not just what do we do as public health, but how are we doing it? So how are we scaling this equity work that is about justice and deconstructing the historical consequences of racism, classism, gender discrimination? But how are we also looking at the onslaught of demands on our profession and scaling that in a way that is equitable, honors our capacity, honors the people that we're serving? Second learning lesson is walking the talk. We're very good at talking the talk, but we're learning that everybody that says health equity does not mean health equity. And so how do we drive an authenticity to that space? We're also pretty good, as Julie Gerberding said at an APHA conference, she talked about chalking the talk. We're getting pretty good at even writing about it. But this idea of how do you do equity, or what does equity in action look like? And again, I want to underscore that if we're tiptoeing around the historical legacy of racism, gender discrimination, classism. I loved the first presentation with all those gender inequities demonstrated. If we're not addressing those things head on, then we're not really doing equity. You've heard a lot of comments aligned with what I'm calling the tyranny of turnover. It has been taxing. Not only are we subject to the great resignation, but I recently learned of this concept called the hidden resignation, which is the consequence of all those folk leaving. And then we've got colleagues now that are still in their jobs, but they really have shut down. I appreciate Nicole's comments about trauma. How are we supporting the workforce that remains in a way that keeps them whole, keeps them healthy, and honors all of their contributions? A couple of more learning lessons. Interesting, this idea of flipping the dominant bureaucratic narrative. So we have found many staff in that space of burnout are like, I'm so frustrated, all of this red tape. Basically, it's no fun working in this space. Government is sluggish and they're inflexible. But we've had to, in order of keeping these staff whole, talk about how do we flip that dominant narrative. That is not the narrative, or it certainly shouldn't be the narrative of our lived experience in public health. So if it's not sluggish, what about it's accountable? What about it's disciplined? What about it's structured? We are dealing with taxpayer dollars, and yes, there is a greater level of accountability. We love tools in public health, but getting people to push more deeply to finding the tool. You may have heard the quote that if you're a hammer, everything looks like a nail. The solutions to our shared problems are really distinct across jurisdictions. Fidelity to model, I just always want to push a little bit on, because oftentimes I would submit that is when equality becomes the enemy of equity. This is not one size fits all. We find that across our state. We find that across the national partners with whom we are engaged. And lastly, the issue of politics versus political will. We have seen the hyper politicization of our profession. It is heartbreaking. It is taxing and challenging, but not just focusing on the problems, but the possibilities of our having the political will as a profession. And so I just close with a quote to leave you agitationally thinking about innovation. Seneca says, it's not because things are difficult that we dare not venture. It's because we dare not venture that they are difficult. Honored to be a part of this profession and a part of this panel. Thank you, Valerie.
Thank you so much, Renee. It's a really nice way for us to wrap up. I appreciate the opportunity of the National Academy of Medicine and the Roundtable on Population Health Improvement, giving all of us who are so dedicated to public health and population health workforce an opportunity to highlight some of the innovations that we've been witnessing through the pandemic and through this last year, and to give us a chance to think about ways to apply some of these innovations in other settings and to continue to address some of the ongoing challenges we have in workforce recruitment and retention. Please join us again in just a little under 30 minutes. So 3 p.m. Eastern Standard Time, we will be having the third panel that's focused on competencies and training and pathways for the workforce. So we'll be taking a short break. If you do have questions for our panelists, we'll be trying to answer those online for you. So please feel free to write them into the Q&A. Thank you to all of our panelists, and we'll look forward to the third session shortly.